Great. You can hear me? Hello. So I want to start by saying that I'm using this really cool presentation template from Denver, from MAPS conference. I kind of stole it because I like it so much, so thanks MAPS. And I also want to say, I want to start with a bit of a reality check because I came to Geneva from a WHO Euro regional meeting, which is bringing together 53 countries. WHO Euro region is big. And there were all the kind of health leaders there from all over the place, all the member states, health ministries, representatives, diplomats, people who really are making health decisions, and WHO and international organizations. And I wasn't there in my capacity as a psychedelic advocate. I was with a different hat, but I was kind of sneaking in discussions on psychedelics, and virtually no one had any clue about psychedelic therapies and what has been happening in the last 1 or 2 decades. So we have a lot to do still. So this is PAREA. We are a membership-based organization which is bringing together already existing organizations, and we do have a number of important psychedelic foundations as members, such as Beckley, but very importantly, we go beyond just the psychedelic sector, and we bring patient organizations, such as Global Alliance for Mental Illness Advocacy Networks, or European Federation of Neurological Associations, because it's, you know, our primum movens really is addressing huge unmet needs in these patient populations, and I am strong believer in engaging patients as early as possible in discussions that concern them ultimately. PAREA also comprises a number of scientific and professional organizations, such as European Psychiatric Association, European College of Neuropsychopharmacology, and a few more. And this is because without a buy-in and trust from those organizations, from professionals, from healthcare professionals, access to even most effective therapies will be hindered. So it's really important to have them engaged as early as possible, and also going outside of the kind of echo chambers, the only psychedelic stakeholders. And also, with this composition, we really have much more representation and legitimacy when we speak with policymakers, because they see that there is more to this work than just you know, some ideas from psychedelic groups. And our focus is on future prescription use within clinical context, and you see also here PAREA's mission. So psychedelics is a Greek word. We are in Europe, and PAREA is also a Greek word, and it means to be in the company of friends, to do something together. It denotes this notion of human connection and being togetherness, which is of course a hallmark, of course, of what psychedelics are. They are bringing us together. Yeah, it's kind of part of who we are. And it also means to party in Greek. This is the PAREA team. Professor David Nutt is our chair. Deirdre Ryan is a vice chair. She represents patient organizations, Pain Alliance Europe. There is European Brain Council also, and so on. Now, what we do a lot of things, but what we really do at the more meta level is trying to create the conditions under which psychedelics will thrive in Europe, and creating this conducive and enabling environment. We do this, of course, first and foremost through education. So we issue regular news releases to a database of all the members of the European Parliament, 700 people, European Commission, different agencies, health ministries, research ministries, scientific societies. This year, I spoke at a couple of meetings. One was for the Congress of the Federation of European Students, Psychology Students Associations. PAREA was also present at the European Pain Federation Congress, and to our knowledge, it's the first time when psychedelics were discussed at the pain scientific community. And I want to mention this Berkeley psychedelic survey results that were published recently, which mentioned that those who report either awareness or use or both had much more positive sentiments and were much more likely to support policy change. So it's really important, and we are trying to build familiarity, especially that many people, many clinicians and patients are wary of psychedelics because of decades of bad press and stigma and current classification. So we have a lot of work to do here, and the public will need to see psychedelics as valid and effective mental health treatments, as real medicines. And I think it also kind of echoes with what you will hear next from Pedro about behavioral insights and kind of turning states into trades, so to speak. We support mental health policies, build relationships with policymakers. We call for more EU-funded research to go to psychedelics, and I'm happy to let you know informally that in January there will be an announcement of a EU-funded project for psychedelics in palliative care. It will be a major project with clinical trial, 4-year clinical trial, 20 partners and 4 clinical sites in Europe. So it will be the first time when the EU is giving a significant amount of money for psychedelics, further kind of legitimizing and destigmatizing this field. So there is also a symbolic importance. Thank you. It's happening. And we partner with media such as Politico, and it's important because Politico has now taken over Financial Times in Brussels as the most influential media, and 80% of EU policymakers admit to be taking political work into account when making decisions. And Politico has been extensively writing about our work. Before PAREA, I'm subscribed to their healthcare bulletin, which goes out every morning. Psychedelics over the period of 8 years were mentioned 3 or 4 times. After PAREA was set up last year, just in the span of half a year, there were like 20 mentions, either writing about our work or about what's happening in general in the field and so on. And it's really important that we have these channels. And Politico is doing kind of an ambitious work, not just kind of adding to the hype. This is what matters to us, ensuring optimal care and safety for participants and patients. We want to avoid a situation where psychedelics are introduced into clinical practice in poorly regulated ways that could harm people, harm patients, that could endanger the long-term sustainability of those medicines. We want to develop expertise in infrastructure, encourage standardization, drive meaningful regulation that will prioritize safety, but also not hinder access unnecessarily. We are calling for an EU-level multi-stakeholder collaboration. We believe that there is an added value of the European Union to come up with certain guidelines rather than having country working on them kind of country by country. And we call for investing in under-researched areas and gradually expanding access. We believe that it will be prudent to expand access slowly and see what works, what doesn't work. And anyway, the indication for which a drug is first approved is often narrower than its target population in a more mature state. So, we will probably start with areas like treatment-resistant depression, but as psychedelics, as say psychiatrists see that psychedelics are efficacious relative to SSRIs, the access could then expand to milder forms of depression and many other areas, but I think it would be prudent to move slowly. And I also want to add this. I'm really happy that there was such a strong focus, kind of this importance of therapy reverberating across all the talks and panels here. And it does worry me a bit seeing, again, a lot of big companies really skimming the psychotherapeutic component a lot. And I think also that for far too long, we've been asking ourselves all the wrong questions, like how we treat depression, how we treat PTSD, how we create better antidepressants. And psychedelics are not just better acting antidepressants, and they are teaching us different questions, like how to engage in the process of recovery, tapping into these innate capacities we have for healing, how to become agents of our own recovery and not kind of just receive some magic pills that will do their work. It's kind of moving from magic pills to magic mushrooms in a way. So they really put an attention back on the human being. And I think ketamine is an interesting example because it can be an acute treatment by itself and there is place for it, but it doesn't heal depression and anxiety by itself. It can provide some temporary relief, and that's great and sometimes very needed, but healing will require work, and that work is most efficiently done with a trained therapist. And I was also reassured by Rick, who said yesterday that he doesn't worry that there won't be therapy, enough therapy, because even just because this combination with treatment and therapy is simply enhancing magnitude and duration of effect, so it will make a financial sense for policymakers to have therapy. And Rick, I was just saying that I got inspired by the MAPS templates in Denver, so I'm using a lovely template. Thank you for that. So in terms of some recent progress, there is a members of the European Parliament Action Group now in the Parliament. There was a number of recommendations from EU institutions mentioning psychedelics. And this is really just top line. There's been so much happening, but PAREA is also producing a lot of policy documents, position papers. You can see a few here, and I'll be speaking about pharma legislation a little later. We just released a policy brief for the European Medicines Agency because they are organizing a multi-stakeholder workshop in April next year. It will be one-day workshop, half day in the afternoon and half day in the morning. And this is something we've been repeatedly asking for EMA to do, and we are really pleased to see this happening. And we are calling in our policy brief for a creation of a multi-stakeholder advisory board that would provide guidance for different areas relevant, such as training standards and accreditation and ethical guidelines and so on. And now I'd like to speak about a long road to access in the EU. And I will start by explaining a little bit the architecture of the European Union. So in the EU, we have 3 institutions that hold executive and legislative powers. These are the European Commission, which is representing a EU-level interest. It consists of different directorates general, such as Directorate for Health, but also has under its supervision a number of EU agencies, such as the European Monitoring Center for Drugs and Drug Abuse, which will be soon changing to EU Drug Agency, also European Medicines Agency. And there is European Parliament, which is democratically elected by EU citizens. There are 700 MEPs. We will have elections next year. And the Council of the European Union, bringing together 27 EU member states representing their interests. So we have a central regulatory approval mechanism for new drugs in a single EU market. However, healthcare provision is a national competence. And this is really a big issue because, in effect, it's like we have 27 health markets. And you can see this really well on this graph because there is a huge access inequity in Europe. One thing is innovation, and a different thing is deploying innovation. So on one hand, clinical advances that translate into, it's about the clinical advances that translate into routine practice in a timely manner. And, for this, you need to have these drugs available. And as you can see here, there's huge variance between time to availability, counting from when a new drug is approved in the EU. And this will be, imagine that we have a psychedelic therapy approved. And then imagine that in Germany, you will wait for it for 128 days. And then in Poland, 827 days. And we are members, Poland and Germany. So it's a big issue. Switzerland is also, not that great. It's kind of closer to the middle. So that's time But there is also another indicator which speaks about the total availability per approval. And so, for instance, between 2018 and 21, there were 168 new therapies approved by the European Medicines Agency, out of which Germany saw most of them. And then, in some countries there was like there is a 10 kind of, there is a variance of 90% or more. So again, this is something we'll be grappling with in Europe, and I will try to explain a little bit why this is the case. So access in Europe depends on many factors, and this is things like whether pharmaceutical companies will decide to market the medicine in a specific country, whether the national health system or insurance company will agree to reimburse it, whether the local pharmacy will have the medicine available when it is needed, and whether the patient can afford to pay the costs if they are not covered by healthcare insurance. So looking at different layers here, starting with global level, it's the decisions that the companies are making, which kind of therapeutic areas they are prioritizing, and of course it's financial decisions, but states can incentivize areas that are in areas of unmet need, can provide incentives, can provide research grants and so on. And this is what the pharmaceutical strategy for Europe will now do. This is going to be revised. There wasn't any revision of the pharma rules for 20 years. They are now being kind of rewritten. And one measure there is to incentivize new areas like antimicrobial resistance. And PAREA is making a strong case for a need to provide incentives to novel mental health treatments, because there hasn't been really much innovation happening in the last few decades, really, whereas the prevalence is growing, and we are really in a deep shit, so to speak, as societies with our mental health, really. So PAREA is pushing for the mental health to be recognized as high unmet medical or societal and health need. Oops, just coming back. Then there is a market placement. So again, companies are free to decide where they will file for price and reimbursement, and they would usually pick the 5 biggest EU countries and leave others kind of to wait. And the EU is now in the pharma proposing this idea that if the companies are not filing in all 27 member states within 2 years, then the EU will take away 2 years of market protection for those companies. So instead of 10, they would have 8 years of market protection. And so this is, we've been very actively involved with PAREA, producing position statements around pharma, because it's a perfect opportunity for us to spotlight the psychedelic sector. Then the next level is authorization, and this is what we are discussing a lot. TGA, just in Australia, approved 2 psychedelic-assisted therapies. MAPS is heading for approval next year. So there is a lot of emphasis in the field on this particular aspect, but as I said, there is much more than this before we actually will see psychedelics available for patients in all countries. So now we are moving to pricing and reimbursement, and it's about health technology assessment. So again, one thing is to have a drug approved, but whether it will be covered by a health insurance, sorry for a typo in the weather, I guess. And so HTA is no longer just about a scientific or clinical assessment that is happening during the clinical trials, but it must take into account financial and economical constraints that when countries are deciding what to include in the basket of covered services and for what price. So the HTA agencies really look at value for money, because resources are kind of limited by definition, so they have to make decisions, where to invest, where maybe to take money from. And so the big question is here whether the clinical trials and whether their positive results will actually transfer to the real world, because clinical trials are done in highly artificial settings, so will they work under normal practices in normal settings? And this will be very relevant also for psychedelics, because things will be very different outside the clinical trials in our field. So it's looking at this actual net benefit produced by the intervention and looking whether the additional clinical benefit compared with the best comparable treatment is proportionate to the additional cost. And then we have last two levels, which is distribution and supply and cost. So there are a lot, again, I listed a few things that I think will be relevant for psychedelic therapies. One is building infrastructure and expertise, and these capacities will need to be built that mirror those in other healthcare professions. There are a lot of things, kind of space, of course, therapists, and kind of, many other things that are related to commercialization, which are very complex when I'm hearing about kind of maps. From Mike Mueller presentations, it's just, it's a jungle, they are charting a new territory, so. And then there is related to this, of course, reimbursement. PAREA is really wants for psychedelics when they become approved. We believe that patients should have them available at the place where they live from the doctor that they trust, and they should be covered by health insurance. So this is the direction of travel. Otherwise, those who are most in need will be left without access if there is no reimbursement, including in lower, and especially in lower income and socio-economically deprived communities, which, as we know, are disproportionately affected by mental health problems and addictions already. So we would be reinforcing this vicious circle of inequities. Then there are things like integrating training psychedelics into standard psychiatry and psychology training programs, looking whether healthcare professionals will be willing to prescribe therapies. So again, there will need to be education both to doctors and patients. And I think that we'll also see evidence expanding with time and accumulating more and more evidence, hopefully, for the long-term efficiency of psychedelic-assisted therapies. And this is the poster from an event that will take place in the European Parliament. You can scan the QR code, or there is a URL here if you'd like to register for a virtual participation. We'll be discussing on the 6th of November the regulatory pathways for psychedelic therapies, discussing how we can make sure that they are accessible in the future and that they are now incentivized. And this is happening as part of this MEP interest group meeting, interest group. So this is it. And as I've been watching different presentations over the last few days, I've been a little jealous that you can all have these cool quotes ending your presentations or somewhere in between. And I was, thinking, where are some cool quotes about EU regulation and access? And I haven't found many. So I thought I'll just segue to a Q&A with this quote. So thank you, and happy to answer any questions.
Okay, hello. I have a question. I'm here on your left. I have a question about the training aspect you mentioned. So how long do you estimate it takes a person, a medic, a doctor, a psychiatrist who was psychedelic naive in terms of therapy before to make them ready for application of psychedelics in daily treatment?
So I thank you for the question. I don't have a personal opinion, because I think what PAREA wants is to have this expert consensus coming from people like, healthcare professionals and psychiatrists and so on, who will together, come up with training modules and determine what would be the good amount in Europe, given taking into account our kind of European specificities. But I'm happy that you mentioned that this training would be offered to healthcare professionals, because I think that's the way to start. So to be a psychedelic-assisted therapist, it's great if we start building on an expertise of people who are already trained, rather than starting with people who don't have any formal healthcare training. So we are talking about not just psychiatrists and clinical psychologists, but other groups, including nurses and so on. But yeah, for the duration, I cannot tell.
Yeah, thank you for your talk and for your work. I saw that there is some sort of EU citizens initiative plan that's either already kind of happening or will happen. Can you tell anything about that?
Mm-hmm. Sure. So PAREA was involved in early phases of formulating the asks, and this is an instrument that the EU citizens have to kind of exercise their democratic powers and voice. And if there are 1 million signatures collected in all 27 EU member states, then the European Union is obliged to take this issue on the agenda and, if appropriate, follow up with some actions. So a EU citizen initiative called PsyCare has now been formed. It's a project which is centered around, the goal really is to collect this number of signatures, and then there is a number of asks which are resonating really with what is important for PAREA. So they include EU-level action on psychedelics, so that EU provides funds and kind of coordination platform that could bring together different actors. And another ask is to have more research to psychedelics, and then also for the EU to take some sort of a leading role in starting or continuing discussions on the need to reschedule psychedelics at the level of the UN Convention.
Hey. Hi, I'm here.
Thank you.
Thanks for all the good work. I would have more of a marketing question. We know that psychedelics, they do have a bit of a bad rep in society, and that has created complications. Do you think that you as a, well, not a policymaker, but as an, a key opinion leader, would it make sense to somehow, remarket those substances? The same way that today we develop drugs for ADHD and nobody cares that they're amphetamines that can be abused, et cetera, then couldn't we just be developing antidepressant drugs or a new class of drugs or something as, not as emotionally charged as psychedelics?
Mm-hmm. I think there have been some attempts. I mean, the concept of psychedelics has been evolving, and also the name, and there are other names which, like psychoplastogens, which denote maybe something different, because these are without the kind of psychedelic subjective effects. But I think, maybe there was an attempt, but for now, I don't think we have anything better. The way PAREA is speaking about these issues is that sometimes we use the term mental health novel treatments, and we will be launching a position paper on unmet medical societal health needs. And actually in this position paper I don't mention psychedelics even a single time, because it's not about psychedelics, it's about making the case to incentivize drug development in the area of mental health, because we have the last 30 or 40 years not much change. We have like 30 antidepressants, maybe 20 antipsychotics, a dozen of other drugs for borderline or ADHD, and these drugs largely stayed the same in the last few decades, mostly just tweaking their kind of safety profiles. So we are making the case, given also the burden, to incentivize this area, but are not mentioning psychedelics. And there is one more thing. Our work, as I mentioned earlier, is really to work towards the society seeing psychedelics as any other medicines. And when we do this, we don't have anymore an issue when we discuss whether we should do trials on children or adolescents and so on, because we are not debating whether we can give, other drugs, like for medicating kids for ADHD, we see this as a kind of pharmacological intervention. So it is my hope that with time, psychedelics will also be seen as valid and effective mental health treatments.
From my experience with psychedelics 50 years ago, when I had a lot of LSD and mescaline and so on, the effects were so completely different from ordinary states of consciousness that I very much feel that it should be a requirement that psychiatrists and psychologists who treat patients with psychedelics have the psychedelic experience themselves. Of course, I have great respect for all the people that are working without having that experience, but do you think that is something that should be further discussed, and are there any moves in that direction yet?
Mm-hmm. So I will start by saying that I'm not maybe the most competent person to properly answer this question, but I can offer, my perspective. I fully agree that it's really important, and I also it is my hope that the majority of therapists would have these experiences anyway, and if there is a small population, there is a few % of those who don't want to, I don't know if we want to kind of exclude them, if this would be wise to kind of have them tick this box or you're out. Maybe for some they will need more time. Also, the core competencies of a therapist, I think they are going beyond just experiencing the trip. It's experiencing subjective experience, but many other things that were mentioned by for instance, Peter. So I guess, this is my view. But again, I see this as the work of an expert consensus of people who know, what they do. And this should involve not just psychiatrists, but psychedelic organizations and people who have been working on the ground and have a wealth of experience, and as much as possible also remembering and including, of course, indigenous communities and people who have been doing this for decades or millennia in this kind of formulation of this type of standards.
Excuse me. Hi. Oh, was someone else speaking? Okay. What is your thinking on psychedelics in children, and what experience do you have? I was encouraged by the group yesterday comfortably talking about underground work. I met some board-certified psychiatrists in Chicago who had been giving it to their own children and were able to take them off these horrible drugs like Ritalin and stuff like that. And had started very low dose, and had been quite successful. Mm. What do you, and maybe you're not comfortable speaking about it, but what do you know about that? And is there any hope for that?
Mm-hmm. Yeah, again, I can offer my perspective, which is not kind of an expert perspective, but a personal one. So of course we are talking about kind of a medical model where you give a medication only when you don't have anything better to offer for a person, and you carefully weigh the benefits versus risks. So you have to establish this. So that's one thing. The other is that I think it will be for the science to answer how effective these treatments are, and this will be ultimately what we should follow. But we should certainly, both asking ourselves this question and conducting science with children to understand how effective they would be. I don't know about psychedelics like psilocybin, who are creating kind of this fluidity in your mind which children already have. So maybe MDMA could be much more appropriate for a child than classical, perhaps. But we don't know, and I think it will be really important for scientists to gradually expand into this area and understand better the effects.
Hiya. Thanks so much for the talk. I really appreciated the pyramid with the kind of different kinds of evidence at different stages, and I was thinking about all these different kinds of evidence, like from clinical trials and epidemiological demographic data and so on. And I wonder if I can get like your reflections on what kind of evidence is lacking most, or what's the hardest kind of evidence you think right now that needs to be provided but kind of isn't there yet?
I think the role of therapy, because it's so complex to kind of disambiguate this and understand what's the best kind of sweet spot and what type of therapies in what kind of context for what types of mental health conditions. So I think we need to do much more work to understand how we can optimize the therapeutic component, because compounds are much more straightforward and much more easy to kind of determine their safety and efficacy and dosage and whatever in trials. But you know, I think this will really take a lot of time and go into the post-marketing authorization data gathering. We'll be using real-world evidence and see what works, what doesn't, and then. Yeah, the long-term efficacy, I know that MAPS has been doing some studies with MDMA, but I think we need much better understanding on long-term outcomes to make payers more at ease with reimbursement.
Thank you very much. Thank you very much, Tadeusz.
Yeah.